Unit 10, Part 2, we are now discussing the normal labor process. Part 1 of Unit 10 was electronic fetal monitoring, which was really originally slated for Unit 9, which was antepartum, but we use electronic fetal monitoring so commonly in labor and really relatively infrequently in antepartum nursing, so I felt that it belonged with this content. But now we're going to discuss the normal process of giving birth and the nurse's role in contemporary intrapartum nursing. We're going to talk about signs and symptoms of labor. We're going to talk about the mechanics of labor. We'll talk about the stages and discuss all the variables that can alter the course of labor and delivery. So we'll get moving on that. So when we're discussing intrapartum nursing and the labor process, it's helpful to kind of know what labor is. And we can sort of take a look at it by comparing true labor from false labor. The real hallmark of true labor is that you get cervical change at the end. Labor is the process of opening the cervix and the descent of the fetus, the presenting part of the fetus, until the birth of the baby is accomplished. And so true labor is typically characterized by regular uterine contractions that maybe start out as mild contractions and become progressively stronger, such that they open that cervix and the baby descends. But we see progressive cervical change, we see progressive fetal descent. That is true labor. Okay? It is the process of giving birth. Now, false labor, on the other hand, and some practitioners don't care for the term false labor. They like the word maybe pre-labor or prodromal labor. But these are contractions that don't really cause cervical change. Or if they do, they cause it so slowly that it's very difficult to determine labor progress. Maybe the cervix is getting a little softer, or it's moving a little more anterior, or it's becoming a little more effaced. But it's not something that you can measure easily. Sorry, I'm just going to rearrange my little... There we go. Okay. So it's characterized by these Braxton-Hicks contractions. And Braxton-Hicks contractions are typically very short, maybe 20 to 30 seconds. They could get up to 40 or 50, but they're irregular. Maybe it's 20 seconds now and it's 50 seconds later. To palpation, they are mild, and we'll discuss what a contraction feels like when you palpate mom's belly. But typically, mom might report that this is uncomfortable, and it sort of depends on her pain tolerance and how little she slept and, what she perceives to be painful. But when you palpate those with your hands on mom's abdomen, you can indent the uterus, almost like if you were touching your nose, the tip of your nose. It's very squishy. Whereas stronger contractions feel more like your chin or your forehead. They are short in duration, they're irregular, they can be affected by lots of things. Mom empties her bladder, they go away. Mom walks, they go away. Mom drinks some water, they go away. And the real key to a false labor, they do not cause that progressive cervical change or descent of the fetus, so no birth is being accomplished. There's a lot of things that are going on. Now, Braxton-Hicks contractions and pre-labor contractions can do some important things. They can start to get the ball rolling a little bit. They can get the body a little bit ready, but mostly it is believed that what those Braxton-Hicks contractions do is they help the fetus start to compensate. The baby's going to get some compensatory mechanisms so that when real labor comes, which is a stress, you're going to have those regular contractions that are longer in length and stronger in intensity. They're going to help the baby. It's sort of like training for a marathon. So Braxton-Hicks contractions can be important, but they can also be uncomfortable for the mom. So this is the mom that comes to triage. Oh, I've been in labor for 4 days. And really, she hasn't been in labor because there's no change that's affecting, the baby's passage into this world. But she is experiencing the tightening of the uterus, and you can measure those contractions on a fetal monitor. Typically what we do for mom is she comes in and it's a labor check, put her on the monitor, make sure the baby's okay, see what her contraction pattern looks like. While you're doing that, she's drinking some water, she's resting, then you can tell her to walk. for an hour and then recheck. So if you check the cervix when she first gets there and it's 1 centimeter or a fingertip dilated, you have her walk for an hour and drink some water. If she's in true labor, that cervix will change. It will get softer, or it will get thinner, or it will open up more, or it will move a little bit more anterior. But from 1 hour to the next, you should be seeing some kind of cervical change. False labor or a pre-labor pattern, you can check that mom, have her walk for an hour. Sometimes your contractions will go away. Even if they don't, if you examine mom, you're not going to find any cervical change. The baby won't be lower, the cervix won't be any different. Now that we know what labor is and isn't, we can start to talk about some of the forces and factors and characteristics that accompany labor. And we'll begin at the beginning. What is it that makes a pregnancy that's been progressing for a number of weeks, hopefully anywhere from 37 to 42 weeks, although sometimes earlier, what makes that pregnancy start to progress towards delivery? And although there are many theories, the exact mechanism is not entirely clear. And as our understanding of that evolves, we can be able to look at better methods of induction, augmentation, and hopefully ways to prevent preterm delivery. But just to keep things simple, it's believed that there are several forces that can impact the initiation of labor. And one of them is mechanical. And the first thing that we're going to talk about is the pressure on the cervix from the presenting part. Whoops, sorry. Okay, so whether it's a head or a feet, usually the head is the best wedge against the cervix. But this is going to really influence effacement or the thinning of the cervix. Cervix that has a lot of pressure from a presenting part is going to dilate from the internal os, the inside, to the outside. It's going to get thinner. Okay, that is the first change that happens. So we talk about that.
No, let's brush my teeth.
Okay, go brush your teeth. Another mechanical force that influences the initiation of labor is the distension of the uterus. And I knew that was going to happen. So as the uterus gets bigger, that fetus, that placenta, the sac, it all gets bigger. It sends out signals to little stretch receptors in the uterus that say, you know what, we've had enough. And this might be one of the reasons why when you see things like polyhydramnios and macrosomia in diabetic pregnancy, or when you see multiple gestations, you have an increased risk of preterm delivery. So when the uterus senses that it's stretched far enough, that's when it'll start to get more irritable and will release prostaglandin, and that is where we get our one of the hormonal factors. So let's kind of clear this out. No, I didn't want to go quite that far. There we go. Okay, and get rid of that. Okay, so now hormonal changes. We're going to talk about the release of prostaglandin. When that uterus stretches, those little receptors in the uterus are going to send signals out that influence the release of chemicals called prostaglandins. Now, under the influence of prostaglandin, the uterus becomes more willing to contract, okay? And that's why we use certain agents in labor induction like, that was on your med template, dinoprostone, also known as Cervidil. This is a prostaglandin insert that's used as a suppository. It looks like a shoelace, and you put it up against the posterior fornix, up against the posterior part of the cervix and the posterior fornix of the vagina. So that is a prostaglandin, and another one would be your Prepidil gel, and that's another prostaglandin preparation. And it's interesting when you're talking about NSAIDs. One of the reasons we don't give NSAIDs late in pregnancy, there are other reasons too, but one of the things that they can do is interfere with the normal labor process by inhibiting prostaglandins. Prostaglandins make you crampy, so they are also the cause for cramping. It's why ibuprofen or NSAIDs are better for postpartum discomfort that are caused by release of prostaglandins. So that's one of the factors that can be implicated in the initiation of labor. Another hormonal change that we see is a decrease in circulating progesterone. Now remember, we were talking a lot about progesterone earlier, maybe back in unit 8 and 9. Was it 9? Yeah, it was 8 and 9. We talked about progesterone as the hormone that maintained pregnancy. It calmed everything down. It slowed down bowel, it slowed down smooth muscle, and it calmed down the uterus so that it would not contract and expel the products of conception. Well, as we get closer to term, we see a decrease in progesterone. Now, just to tie things together, we had a medication called McKenna. It was a hydroxyprogesterone caprolate. And I should have probably put that first because that is the generic. The only agent actually approved by the FDA in the prevention of preterm delivery. And McKenna is a synthetic progestin. And it's used for injections in women who have a history of preterm delivery. That can help you sort of understand progesterone decreases right before labor. Okay, once you get that, you get this irritable uterus that wants to cramp and contract. Okay, and at the same time, we have a cervix that wants to respond to those contractions and open up. So we have that going for us. We also have an increase in oxytocin. Another thing that came from your med template. See, these are all hormonal and chemical factors. Oxytocin is a hormone that's secreted by the pituitary, and as you get closer to term, two things happen. Your uterus grows some receptors that are more sensitive because the influence of estrogen. I'll talk about that in a sec. But you have a uterus that's susceptible to oxytocin, and you have this increase in circulating oxytocin. And oxytocin helps the uterus contract. It helps smooth muscle contract more, certain smooth muscle. So it acts really in two places. It acts in the uterus and in the breast. So oxytocin will again be important when we talk about breastfeeding. But for now, we're worried about labor. Oxytocin is that chemical that causes the uterus to contract. It's also why we use synthetic oxytocin, or PIT, to cause contractions. Okay, so we have that going for us. Now you have an increase in estrogen at term, and Mom will notice this. She'll get stuffy nose. She'll get all the side effects of all this estrogen. She'll get that nesting urge, and we'll talk about that in a minute, and a lot more vaginal discharge and things like that. Her breasts will develop more. But you have this increase in estrogen, and the main effect when we're talking about initiation of labor is that it will increase the sensitivity. Sorry for my typing again. Small keyboard, my fingers are fat. The uterus to oxytocin. Okay? And so now we have more oxytocin, we have a sensitive uterus, we have a uterus that wants to contract, it doesn't have any progesterone to oppose it, and we have prostaglandins, we have a cervix that's a little bit thinner, so you have sort of a perfect storm here, hopefully, when it all works. Now, most of those things were maternal forces, but we want to talk about some of the fetal factors. The fetus is also contributing to the initiation of labor. The baby's getting ready to go out. As the baby matures and gets older, it's going to start to send out some signals that say, all right, I'm ready. In a perfect world, this also coincides with lung development and brain maturity. It can go wrong sometimes, and we'll talk about that too. But the first thing that happens is that you get an aging of the placenta. As the placenta gets older, it starts to have little calcifications in it. The vessels don't maybe work as well. They're still nourishing that baby. They're still functioning fine. But as the placenta ages, it contributes to uterine contractions. That's just it. The uterus gets a little more irritable because the placenta just isn't working quite as well. It's just a little decline in function. It's like it's, creeping towards old age, we'll say. Okay, so then you also get, now because the baby has been spoiled, with lots and lots of good nourishment through this placenta. Now it's starting to age and the fetus has a little bit of stress. So what's the stress response involve? You have fetal cortisol release, and cortisol is implicated in the initiation of labor. This is maybe one of the things that we can use to prevent preterm delivery, because we also see higher levels of circulating cortisol in moms and fetuses that have preterm labor, and sometimes it's stress or inflammation. But we do, as baby gets a little bit stressed and has to respond to that stress, it's got some Braxton Hicks contractions that are making it, practice labor. It's got a placenta that's starting to get a little bit less competent, and now that baby's going to release some cortisol in relationship to all this stress. And that cortisol does make labor more likely to happen. Now, also, the fetus at term, as it gets older, it releases precursors to prostaglandins. And so you have more synthesis. Sorry for my typing again. So now you have two factors that are influencing the release of prostaglandins. Okay, so mom and baby both contribute to the initiation of labor, but truthfully it's a little bit difficult to determine which factors are most important and what we need to target in order to either promote or prevent labor. So now that we have some guesses about what initiates labor, we're going to talk about some of the other forces that affect the process of labor and delivery. And your book mentions the 4 Ps, and this is sort of a nice construct, a way to teach students how to sort of think about all the different factors that go into a successful delivery. Okay, so the first one is the passage. Sorry, I had caps lock. And the passage, we really talk about the pelvis and the surrounding structures. Pelvis is probably the one that we're most concerned with because it's, constructed of bone and it's a little less easily altered or manipulated. And we have the passenger. And the passenger is your fetus. Some people include the placenta with that, but really, placenta really doesn't influence birth that much. So we're really talking about the fetus, and we'll talk about different positions that the baby can be in that are more or less favorable for birth. But the fetus does influence labor. And we have the powers. And by the powers, we are talking about uterine contractions, those involuntary muscle movements, and maternal pushing efforts. And that would be in second stage to help move the baby down. That's the powers. And then we have psyche. And these are emotional or psychological factors that influence birth. And they do have a serious effect on labor progress, probably because of the hormonal changes that occur as a result of stress or emotional response. But we'll talk a little bit about how each one of these factors influences labor and birth. So when we talk about the passage, we're usually talking about the bony pelvis. To a lesser extent, we're also talking about the soft tissue structures, and I'll mention that later. But you can see the bony pelvis here, and this is made up of the innominate bones. You don't have to memorize it, it's just a review of your A and P, which are your ischium, your ilium, and your pubic bones. And then you have the sacrum, which is in here. Let me just kind of point to that. That's your sacrum and your coccyx. And then there are the joints and ligaments that sort of connect all these structures into like one almost fused structure. So that's your bony pelvis. Now, we already kind of talked in antepartum about the, when we go for that first visit and the provider does a pelvic exam, they're looking for that diagonal conjugate, and what they're really looking at is sort of the diameters of the pelvis. Or is this going to fit a baby through? There's really no way of knowing for sure until you give it a trial. But if you feel like a really tight arch, and if your diagonal conjugate is less than that 12.5, it's a pretty good indication that there may be a little bit of disproportion if your baby is a normal or larger size. When we're looking at the pelvis, we're also looking at the shape of the pelvic inlet. And I want you to understand something, that you cannot see this from the outside. You can't palpate it from the outside. And it's very actually difficult to determine it even with a good pelvic exam. There's a lot of structures in there. And we don't do x-ray pelvimetry anymore, but there are 4 basic types of pelvises. And we touched on them briefly in antepartum, but here they are again. I'll put my pointer. That's your gynecoid pelvis. You can notice that the shape is nice and round. It's sort of ideal for fitting a baby through. We have the android, which is a male-shaped pelvis, and this is much less ideal. With a small baby, you can sometimes still accomplish a vaginal delivery. You have the anthropoid pelvis, and that a lot of times you can also accomplish vaginal delivery. It may be a longer labor, but you can see the diameter is large enough to fit a decent sized head through. But this platypeloid pelvis, which is sort of flattened in shape, really does not bode well for a vaginal delivery. So that's another factor that we are concerned with. Okay, we're also concerned to some extent with the soft tissues. Now, soft tissues will generally stretch, but it does explain why first-time moms take longer to achieve delivery, take longer to labor, because their soft tissues have not yet stretched. And so when we talk about the soft tissues that influence labor and delivery, we talk about the lower uterine segment. And that is the part of the uterus that basically flattens out and opens up and lets that baby come out. We have the cervix. The cervix can influence birth. If you have scar tissue, it can be more difficult for the cervix to dilate. If we have weakened cervical integrity because we've had repeated DNCs, or we've had maybe LEEPS procedures or other conizations, other procedures that affect the cervix, we can sometimes have dilatation when it's inappropriate, which is our incompetent cervix. And then we have the pelvic floor muscles. And again, most of the time these are not a problem. The vagina, these are very distendable structures. They will stretch. It just takes longer in your first-time moms, hours longer, to dilate the cervix, to flatten out that lower uterine segment, to have the pelvic floor muscles and vagina stretch. They usually do stretch. It just, like I said, it takes longer for that to occur in a first-time mom. So the next consideration, the next force that's going to impact labor is the passenger, and in this sense we are talking about the fetus or fetuses in a multiple gestation, and there are some factors that do impact birth and delivery, and the first of them would be fetal size. Obviously, the bigger the baby, the tougher it is going to be to get that baby down the birth canal. So macrosomia impedes progress. In particular, we worry about something called cephalopelvic disproportion, which is what it sounds like. The head is too big for the pelvis. And we can also have problems with shoulder dystocia. When the head goes through the pelvic inlet, but the shoulders are sort of hung up on the ischial spines. Sorry, let me kind of lower those so you can see them a little bit better. So fetal size is definitely a factor in the birthing process. Okay, so another factor that impacts labor and delivery is called fetal attitude. Okay, that's kind of a funny phrase. It's really not about the fetus's psychological state. It's about the relationship of fetal parts to one another. So I'll kind of put that up there. Sorry. And generally what we're saying is whether or not the baby is flexed. A flexed position is going to give the baby's head the best diameter to come down. I'm going to show you a picture of what fetal attitudes can look like. There it is. Okay. There. Okay, so baby A all the way on the left has general flexion. That's normal attitude. And that's really the best position to come down in, because you see, that's going to give you the smallest diameter. And then the biggest diameter will go through and sort of make that passage stretch. And we can get that baby to descend through the pelvis and the soft tissue structures. But really, this is the best for getting through the bony pelvis. It just gives you the best angle. Baby B has a neutral or military position. I'll put these down. I don't want you to memorize them, but I do want you to sort of be familiar with how this could impact a labor. Okay? And then your baby B was your neutral or military attitude. And that baby's going to have a tougher time coming down, because take a look. Let's get that pointer out again. Now, instead of having this little 9.5 centimeter diameter, now you've got a diameter that could be 10.5, 11 centimeters. It's a little bit wider, and if that baby just has to bump up against that pelvic inlet over and over again and not descend, then you're really not going to get a whole lot of labor progress at a certain point. So your next position, you can see baby C is even worse off than baby B. Now we have extension. This baby's really not going to do too well coming down the pelvis, because now you've got an even bigger diameter right here. And those bones aren't going to stretch to accommodate that. So either that baby is, if the baby's real high up, maybe you'll get some flexion at some point, and that baby will be able to come down. Or if you have a real preterm baby, you might be able to have a delivery. A lot of times, preterm babies don't have the tone that a term baby has, just because they haven't developed that neuromuscular tone yet. So that, 28 or 30 weeker might be okay in that position, but a term baby really isn't going to make it through the pelvis in most cases in that position. And now we have sort of the worst case scenario. We have hyperextension. And that's baby D over here. And you can see this is really not happening. I mean, really, even in a preterm delivery now, you kind of wonder about this head that's hyperextended, how you're going to get this baby out. It's not going to be able to perform the cardinal movements. This is a baby that, unless you can somehow get the baby to convert to a more natural position, you're really not going to get a vaginal delivery. The next term we're going to be concerned with is the fetal lie. And this is defined as the relationship of the longitudinal axis of the fetus to the longitudinal axis of the mother, and it's just a fancy way of saying whether the baby is straight up and down or sideways. Let me give you a picture. Sometimes a picture makes those words a little bit more clear. And here we have, yep, that's it. Okay, so fetal lie. We have the longitudinal lie. This is a straight up and down vertex presentation. Vertex means head first. So that is a longitudinal lie. We have another type of longitudinal lie, and that is a breech presentation, and that's buttocks first. But that baby is straight up and down, just like mom. Okay. Then next we have what's called a transverse lie, and this is when the baby is laying sideways. Okay. The longitudinal axis of the fetus is perpendicular to the longitudinal axis of the mother. Don't use the big words if you don't want. Just the baby is sideways. Transverse means sideways. So that is obviously another factor that's going to influence labor. You can get a vaginal delivery from a vertex or a breech presentation. You will never get one spontaneously from a transverse lie. Occasionally, when you have a baby in a malpresentation, you can do a version. And a version is when you kind of turn the baby either externally. External version is done, well, I've seen them do it in the C-section OR, and they just kind of manipulate the abdomen. They put a lot of pressure. It's pretty brutal to look at, and they usually give mom an epidural so she has some anesthesia on board. Sometimes they can turn that baby head first, And sometimes they can do an internal version, and that is more common when you have a twin. Maybe twin A was vertex and they delivered twin A vaginally, then they reach up and they turn baby B from a transverse lie into either a vertex or breech presentation. But obviously, if you have a transverse lie, labor is not going to be very effective. You're not going to have a head that's pounding on a cervix to flatten it out and thin it out. You're not going to be able to descend through the pelvis. Obviously, that fetal back or shoulder or whatever the presenting part is going to be isn't going to be able to fit through the pelvis or the vagina. And so that's sort of incompatible with a spontaneous vaginal delivery. And while we're talking about vertical and transverse lie, we can talk about an unstable lie. An unstable lie is basically either one of those things that doesn't want to stay stable. So you can flip a baby with a version and get them from breech to vertex or from transverse to vertex, and they can sometimes flip right back. So that unstable lie, can cause some problems also. Another way that the passenger influences labor and birth is through the presentation, and that's the presenting part is the part that goes into the pelvis first. We have some basic types of presentation. We have cephalic or or vertex. It means the same thing. That just means head first. That is your most common and is the most favorable for delivery, as we already saw with the lie and with the attitude. Head first is the way to go. Breech. And breech can be either footling or frank. Frank breech has the buttocks first, footling, just like it sounds. We're looking at feet first. And here we have a picture of breech presentation. And on the left, we have a frank breech, buttocks first. On the right, we have a footling breech. There's the foot. Okay. And so that is what happens with a breech baby. Now, obviously, a head is harder than a butt or feet. And so when you're having contractions, that head really helps to sort of put, more pressure on the cervix. Feet don't put as much, and obviously the buttocks don't put as much pressure on the pelvis. However, babies have been known to deliver in either the frank or the footling presentation breech, particularly smaller preterm babies. And the big danger is that because the presenting part is smaller than the head, sometimes the cervix isn't fully dilated when that body comes down, and then the head gets trapped in the cervix, and the cervix kind of clamps down and causes like a strangulation hazard. So that's one of the dangers of having a breech birth. Breech birth does take longer than a vertex birth. So that's another factor that influences labor. We have face presentations. And face presentations, you can rarely have a vaginal delivery out of this because this is that, extension. And I'm not going to tell you that it never happens, but depending on which way that baby is facing, it is very, very difficult to get the whole face through that diameter, that pelvic inlet. And here's a picture of the face presentation. I'm going to blow it up just so you can see what's going on there. And if you take a look, the baby's face is coming out, and that's that hyperextension of the head. Now you can see, obviously, this is a much bigger diameter. Mom's bones don't want to let that baby through. It's really not favorable, and the baby's not going to be able to do all of those cardinal movements that we're going to talk about later. So this is really not a good scenario for birth. Every once in a while, you will get a baby who can deliver in a face presentation. Again, you're talking mostly about smaller or preterm babies, but it is not easy. And it kind of depends on which way they're facing. If they're facing so that their chin points to the back, that sort of gives you one possible outcome. If they're facing the other way, it's a little bit more favorable. And sometimes the sign of this, sometimes you can feel it on a pelvic exam. I have not really had too much experience with face presentations. I've had one, but I didn't examine that patient. Sometimes you can feel that you're not in the fontanelles. It depends on how far the baby gets down. If the baby's, very high, like a -3 station, station's a concept we're going to talk about later, you might not really be able to feel the facial features. But if the baby makes it down a little bit lower, if you're able to reach, you may be able to palpate the features of the face. The one face presentation I had, I remember coming in and the mom was about 9 centimeters dilated. And the nurse who was coming on, or was leaving, the day shift nurse, had tried everything she knew. She was one of the more patient nurses. She was really into different ways of positioning mom to help labor come down. Mom was very committed to an unmedicated birth. She came from a different country too. And I remember the midwife was just very frustrated and, can you just up the pit? We just need to up the pit and get that baby out. And the baby just wasn't coming no matter what we did. And finally we got the doctor who was covering the midwife, and he sort of got the ultrasound out and said, this baby's in a face presentation. And so we had to explain to the family that most likely we were going to need to deliver by cesarean section. And that is the most likely outcome with a face presentation. It's overwhelmingly likely that that's what's going to happen. Okay, another type of presentation is a shoulder presentation, and just like you would imagine, the shoulder comes first. This is not a good scenario for vaginal delivery. Again, like I said, if you have a twin B who is coming out this way and you've got some room to manipulate and baby A made it through, you might be able to sort of rotate this baby in utero, vert this baby, and get them to come down in a more natural position. But almost always, if that baby is coming down shoulders first, you're really not going to get a vaginal delivery. You're going to have to deliver by cesarean. So the next concept we want to talk about in relationship to the passenger is the position of the presenting part. Okay, so when we talk about position, there's a 3-letter notation system that is used to describe that. What we are describing is the position of the presenting part in relation to the maternal pelvis. So just give you a minute, you can take that note. And that's what we're attempting to do with this 3-letter system, okay? So the first letter is either going to be R or L. Let me make that a little bit bigger for you. And the R or L is going to describe which side of the mom's pelvis the presenting part is on. I want you to take a look at this picture right here, okay? And you'll notice that all of these pictures have a baby that is occiput first. So the occiput's the presenting part. What's different is whether it's on the right or left, and whether that occiput's anterior or posterior or transverse. But take a look at the difference between this baby, ROA, and this baby, LOA. They are both occiput anterior. One is on mom's right. The occiput is on mom's right. Okay, remember we're looking at mom's right, not our right. Okay, and this baby has the occiput. Here's the occiput. The back of the head is on mom's left. The back of the head is going to be the same side as the baby's back. Remember when I taught you Leopold's maneuvers, we felt for a back and head. So whatever side the back is on is where the occiput is. If the occiput is the presenting part, we're going to look and see, is it on the left or the right? Again, it's mom's left or right, not our left or right, okay? So that is the R or L. Is the baby on mom's left side or a baby on mom's right side? And we're really not the whole baby, but just the presenting part, okay? So that's what your R or L stand for, okay? Let me make that a little smaller. I can make a lot of this smaller and make more room for other stuff. Okay, so our next letter is going to be, I'll get rid of this picture too. I have a better picture for that part of it. It's going to be O for occiput. If the baby's presenting part is the back of the head, which it typically is, or it can be S for sacrum if the baby is breech, or it can be M for mentum. Now it's uncommon to see sacrum and mentum, but it does happen. So when we're describing the second letter, it's whatever the presenting part is. If it's the occiput, if it's the sacrum, if it's the mentum. Now those are really the 3 that are going to make it into the pelvis. If you have like a shoulder presentation or some kind of weird transverse lie, nothing is going into the pelvis. Nothing is presenting. really. I mean, you can call it a shoulder presentation, but that shoulder is going to be wedged kind of up high. It's not going to come down at all. So that second letter is either O, S, or M. Okay, let me show you a picture of that. Okay, so all of these babies are on the left, but they have different presenting parts. This baby up here, what a good boy he is. Assume it's a boy, could be a girl. But this baby is coming down occiput first. We like occiput first. We've already mentioned when we talked about lie and attitude and presentation, that's the best way for baby to come down. It's going to be the way that makes the most sense spatially. Other presentations don't work as well. Here is your mentum presentation, or your face presentation, and you can see how tight a fit that is. Now again, I mean, depending on which way the baby's chin is pointing, you might get the baby to come down a certain way, but it's almost impossible to get a whole baby out of here when their heads are hyperextended like that. So that is where your middle letter comes from. Your M for mentum means that baby is coming down face first. Okay, now look at your last baby. You have S for sacrum, okay? That means that the sacrum is the presenting part. The baby's back, or the baby's buttocks, really, is the presenting part. Again, you can get a baby out vaginally this way. It's just tougher, and you run the risk of head entrapment, particularly with your small babies, because the cervix doesn't need to be fully dilated for the body to slip through. So that is your second letter, your O, S, or M, okay? Now for your third letter, you are looking at whether the presenting part is anterior, which means it's coming from the front. Let's see if we can find. There's an anterior presentation. There's another anterior presentation. It means that the presenting part faces towards the front of mom's pelvis, towards that pubic bone. So the back of the head faces the pubic bone. That's ideal. Anterior positioning is the best. We like that. Now, the other two ways that it could be, you can have a baby who is in posterior position. And here, the hardest part of the baby's head, the back of the head, is up against mom's sacrum, which is posterior. These are your ROPs, LOPs, direct OP. An OP baby, the thing that I want you to take home from that is that is where your back labor comes from. And we talked about this in labor support. Oh, it doesn't want to shrink my picture. All right. Okay, never mind. Your posterior babies, the hardest part of the head, the presenting part, and also the part that's coming first, is rubbing on all of those nerves that are in mom's sacral area and causing excruciating back pain. It also increases the diameter of the baby's head that has to fit through the pelvic arch. And so this is a prolonged labor if you get a baby out of it vaginally at all. Some moms can deliver a direct OP, or a right OP, or a left OP. Some moms can't. It depends on how flexible those ligaments are, how big the baby's head is, and how wide mom's pelvis is. So OP is going to slow your labor down. A lot of your OP babies, your right OP, left OP, or direct OP babies, are going to convert. They get annoyed by their heads are hurting. Just like mom's having back labor, they're having like head labor. It hurts a lot. And eventually sometimes they will rotate and then they will descend. Often a labor that's been very prolonged, once that baby does sort of rotate, it goes much, much, much more quickly. So that is a posterior baby. Now our last initial is T for transverse, and these are your transverse. Okay, your right OT and your left OT. Okay, and that means the baby is sort of sideways, and that is going to also take longer. Again, as long as your baby is flexed and your occiput first, you have a pretty good chance that this baby is actually going to rotate and come down in more of an OA position. If that happens, then all's well. If not, you're looking at maybe a protracted or prolonged labor. The most common position for a baby to be in at term, by the way, is this LOA position right here. Okay? And you can confirm all of these with Leopold's maneuvers to some extent. You can see them on ultrasound. But another way that you're going to be able to tell is where you're placing your fetal monitors. Okay, one more concept that you can learn about how the passenger sort of determines labor progress is station. How far down is the baby? So we use the ischial spines as a guide, and I'm going to call your attention right here is 0. This is the ischial spine. You can feel this. You know, a great time to do this is after mom's had an epidural and maybe you've gotten Foley in, so you don't have a big full bladder. The baby has a chance to kind of come down, and you can kind of feel around a little bit while mom is comfortable and sort of feel those like ischial spines right here. And they're going to feel like little sharp bony things, unless mom's really morbidly obese, and then you won't really feel them too well. But in relation to the ischial spines, if the baby's head, the presenting part, has made it to the level of the ischial spines, you have a station that is described as 0 station. Okay? If you have a baby that's floating above that, it's 1 centimeter above the ischial spines, your baby is -1. 2 centimeters above the ischial spines, your baby is -2. 3 centimeters above, your baby is station -3. Above that, a lot of times we call it floating, and then usually the practitioner will describe the baby as laudable, which means you can kind of push on their heads and they bounce a little bit. When you're talking about negative numbers, you're talking about a baby who hasn't descended very far. Now you have the positive numbers. Here's a little mnemonic that we used last year that kind of helps some people. +4 is on the floor. And what that's telling you is that the further down you go below the ischial spines, obviously the closer you are to having a delivery. And +3, usually, you know, the baby's head is right there. You do a vag exam and you can kind of feel a baby's head right there. +4 is really where we're starting to deliver. And so that is really the concept of station. The last thing that we're going to talk about, let me sort of get rid of some of these things. Oops, sorry. So the last concept that we're going to talk about is, in regard to the passenger, is cardinal movements. And cardinal movements are little adaptations. Many of them are movements that the baby makes to kind of help him or herself facilitate that delivery. And it's kind of a cool thing when you watch it in real time. You'll see little movements that the baby does. They turn their heads from side to side, or they rotate when they're being born, and you can see how they kind of help the process along. So we'll talk about the different cardinal movements. And the first one we're going to talk about, I did put up a picture of the cardinal movements. But the first thing we're going to talk about is engagement. Now, in the first top right-handed picture, or top left-handed picture, I'm sorry, you see the head floating above the ischial spines. This baby is not engaged. Here in picture 2, you have the engagement, okay? The presenting part, which is the occiput, is now in the bony pelvis. Okay, so that is engagement. That is the first of the cardinal movements. The next one is going to be descent. And descent is the process. It's influenced by uterine contractions and mom's pushing efforts. But this is the baby who is moving down through the pelvis into the birth canal, eventually out. So we have some descent here, but more here, further descent. And this is where mom starts to feel a lot of pressure, and maybe her expulsive efforts, if she is fully dilated, will help the baby along. Okay, the next thing, the next cardinal movement is flexion. Now, the smart babies know to be flexed, and certainly the longer the labor progresses, the more those contractions happen. That baby should, hopefully, really tuck that chin under into the chest to sort of maximize the space that they have to get that head out. If they go through with that smallest diameter first and then the biggest diameter, it stretches everything very nicely and makes it easier for the baby to come out. So we have engagement, then descent, then flexion. Okay? Next, and this is kind of the coolest one to me, is internal, well, one of the coolest ones, internal rotation. And this is where the baby like turns. At first their chins are sort of tucked into their chest straight on, and then they turn their heads to the side, again to make more space. And it's kind of like watching like a little kid try to get a turtleneck on, and they turn their head from side to side. You will watch this when you see somebody pushing. You'll watch that little head sort of twist from side to side to make the biggest space. And it turns out that the baby really sort of has to, if the shoulders are sort of towards the front, towards the pubic bone, the head has to look down at the floor. So they have to turn their heads in order to sort of make the best space. I have a video that shows this really well, but here is the internal rotation. You can see the baby is sort of turning his head so that he's facing the floor. And that is also going to facilitate delivery, because he's going to be able to tuck that head under the pubic bone and under the pelvic arch and really sort of help himself out there. But it is neat when you're pushing with somebody, say they start at like 0 or +1 station, when you start seeing the head move down, you really start to see them turn their little heads, and you're like, oh, look, he's helping. So that is internal rotation. The next thing that we're going to do is see extension. And that happens as the baby's head emerges. That happens right here. That's when they find their way out of that turtleneck and they stretch their heads up and say, wow, there's more room. And that extension does sort of help, because it's going to help those shoulders tuck under the pubic bone. The head should be, theoretically, the biggest part of the baby. Hopefully, we hope. When the shoulders are bigger, it causes problems. But extending that head, again, will sort of help those shoulders pass underneath that shoulder. Next, we have restitution, which is also called external rotation. And this is a cool thing, too, is that, you know, as their head comes out and you're watching, the provider will hold the baby's head in their hand, and the baby turns his own head sharply sort of to the side so that he's back in line with the shoulders. So that's your external rotation. He rotated internally when he was still inside mom. Now he's on the outside, and he is externally rotating to get himself out. And that's what that picture looks like. See here, they're looking sort of, you know, they're looking down at the floor, then they sort of look up, poke their heads around, and they turn around to the sides, because now it's more comfortable. They don't have to twist their little necks. They're back in line. This picture shows delivery of the anterior shoulder, but that's really what we're going to talk about as the next cardinal rotation is, our next cardinal movement is expulsion. And that happens, the shoulders slip under the symphysis pubis, and the rest of the baby is born really quickly usually. Unless there's a problem, if there's a cord holding things up, or if there's a shoulder dystocia, which is a complication, it's not the norm, that baby is going to be born very, very, very quickly. After the head comes out. As I said, the head hopefully is the largest part of the baby. So those are the cardinal movements. And the next thing that I'm going to do is play that little video for you. So we'll get that going. And see if you can pick out all the different cardinal movements. See if you can see the baby engaging and descending. See if you can see the flexion, the internal rotation, the extension, the external rotation, the expulsion. Kind of pause it at different points if you have to, and sort of make a note of how that all happens.